Good morning, everybody. And first of all, of course, I want to thank very much Rod, Jens, Linda, Alexei, that everybody that helped me. It is a great honor for me to be there, and I want to thank you particularly. Yes. Yes, it is an horizontal plane deformity. Why? Because it is not so easy to address and understand what is the horizontal plane. Horizontal plane, it is not the view given by a CT scan cut. It is a 3D reconstruction of the entire spine. This is coming from the concept that you know of cone of economy and the chain of balance. And you know, long time ago, oh là là, qu'est-ce qui se passe? 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 Faut aller en arrière. Alors, long time ago, you know, long time ago, you know, the horizontal plane was there. Even in this very nice Adam's book, you see that the picture of the Adam's book and that is coming from the new generation of X-ray are very similar and nothing new. But here, of course, long time ago, you know the plan d'élection of Pierre Stagnara, you know the torsiometer of René Perdriol. It was clear that at the computer era, you remember that we did computer reconstruction of the spine by simple lines, then surface, then volume. And you see that the horizontal plane is still there with the piling up of the entire spine. This is an important thing. And remember when I was at the SRS meeting Chicago, 1980, I tried to introduce this horizontal plane for the prognosis of infantile scoliosis, where it is very clear that when you see from the top, you understand what is the horizontal plane between the spontaneously resolving. But I was not understood. I described the crankshaft phenomenon, and when you see here very clearly, when you see the patient that had an early fusion with a not completely reduced deformity, you see that happen with time. When you look from the view from the top, this happen easily to be understood. And of course, after that, I don't know why it don't work, but perhaps when you see, je voudrais enlever ça, mais j'y arrive pas. C'est trop compliqué. Alors, voilà. Ah, je vois là. Alors, pourquoi j'ai appuyé là-dessus? Je ne vois plus rien là. C'est un problème. Afficher standard.
Jean, everything okay?
Ah, voilà. So when you see the scoliosis, there is two different entities. You have that I call the ascending one, developmental. When you see the progression 6 months, 18 months, when you look for the representation in the horizontal plane, you see evidently that it is an horizontal plane deformity. And then, je ne sais pas pourquoi ça passe pas. Why it don't work?
Would you like us to advance your slides for you, Dr. Dubousset?
What?
Linda can advance the slides. If you just say next.
Because when I push on my button, nothing works. So when you see the second type of scoliosis, that's the one that appear in the adulthood, it is the kyphorotatory collapse, and the starter is still on the horizontal plane. And you see how it's producing this. When you see the rotatory dislocation phenomenon, look very well on the left. You have the widening of opposite direction of this space above and below the unstable vertebral. That is the junctional mechanism, and you see that this scoliosis that happened between 16 and 39-year-old. You see the dislocation, the junctional. It is an horizontal plane deformity. And when I recommend you to read this paper that we wrote with René Castelin, Pasha Chang, and Jack Cheng on the Journal of Bone Mineral Research. It is evident that to get a scoliosis, first you must have an horizontal plane deformity. Of course, the CT scan was a major advance, but it was multiple slides necessary and the radiation dose was not acceptable for the children. But it is why with Georges Charpak and the ENSAM in Paris engineers, I pushed to produce the AOS imaging system with a very low dose of radiation, but everybody use it on the AP, sagittal, but nobody asked the horizontal plane that the machine is able to give you this. And of course, it is a new way to analyze spinal organ, but very few people ask for this view because they have not learned to read. And if you read this picture, you see, of course, the gravity axis, you see the positioning in the lateral, in the frontal, in the sagittal. Each vertebra can be analyzed separately. And from this model, in the engineers' laboratory, when you have this model, mechanical and geometrical, when you push with the yellow arrow on this model, if you have not intervertebral rotation, you never get scoliosis. As soon as you have an intervertebral rotation, then you got the scoliosis. And you see here the progression of a scoliotic curve. It is a 3D torsion, but mainly an horizontal plane distortion. And you see here better the 3D evolution of the scoliosis curve. When you see from the top, you see very well that is a torsion, that is a horizontal rotation. And of course, to simplify, visualize, analyze, quantify, with the EOS technology in the horizontal plane, one of my pupils, Tamas Iles from Hungary, designed the 3D vertebral vector. That is, each vertebra represented by one vector. And you see the difference between the normal spine, the right thoracic scoliosis, pre-op, and you see post-op that you are able to analyze this very easily. And when you see here these two cases, pre and post, you see in one glance, when you use the vector, they are much more visible than we have the complete reconstruction. And I will say to Larry Lenke that he did a very good classification but he describes the lumbar modifier, the sagittal modifier. But you see on this group of 300 cases, when you divide in subgroup, and when you use it for the different horizontal plane aspect, you see that it needs this horizontal modifier. One case you see here that you evaluate with the vertebral vector, you see very well on the frontal view, on the sagittal view, and on the top view, you see very well this motion that is on the horizontal plane. And in this case, you see clearly that the correction is not very complete, but you see very clearly the correction that you have obtained. So if you use a landmark with the vertebral vector, when you see from the top, when you delimit the area of the cone of economy where the spine must be, you have inserted your patient here, and you see you can check the amount of correction you got. And if you are in the A and B localization, it is acceptable. If you are outside, it is out of the cone, and your result will not be very good for a long time. For example, you see this degenerative scoliosis with L3, L4 studied by the vector. And you see it is very evident when you see the dislocation, and you see the dislocation L3, 4 when you see it. It's much more visible. And simultaneously in Montreal, where Cartilage, Coban, the SRS 3D group try to get a 3D classification that is appear based on the maximum of deformity of each segment. But when you use a vertebral vector, it is as reliable and easier to measure. Are we able to measure to predict the revolution, the evolution of a mild scoliosis? We did that at the ENSAM Institute in Paris with an engineer from ENSAM, starting from the 3D EOS imaging model. And when we measure the torsion index, curve angle, that is all the horizontal plane, and we can predict at the first exam, thanks to the severity index, the ones that are stable, the ones that will progress. For example, here, when you have this 10-degree curve angle, you see these two curves. And when you have the 3D reconstruction, what we look? When we look AP, sagittal, when you see the view from the top, horizontal plane, you see very, very clearly the difference. And it is because you have, in one case, you have the horizontal plane deformity. So when we have this severity index, the validation was well classified in 44 cases. At the first exam, you can predict that this scoliosis will progress or not. Why it is important? Because when you have defined this, you can say, with a mild cord, we will treat at 10 degrees, we will not wait for the X-ray progression. We will treat, for example, with a night brace, but a night brace that try to obtain the detorsion, because the curve angle means nothing. It means only collapsing of the spine. It is a detorsion that is the only important thing. The dogma based on the unique curve angle failed. For example, here, SRS criteria, you have this 12-degree curve angle, reserve 1, 2. No treatment. Why wait for progression? Because, and in this other case, the same, that has progressed, COB 25, reserve 4, 5, and you see, no treatment. Why? Because the maturation of the soft tissue is not known. And this is important. For example, it is the two same case. In the first case, the severity index was 0.9. And why no treatment? The treatment has to be done. And for example, you see here on these two X-ray, you will see clearly, look at the arrow. The rotatory dislocation is there. What do we know about the maturation of the soft tissue? We are addicted by the bone. For example, you see here, it is the same case, the dogma of the angle. But if you look precisely in the circle, you see that the rotatory instability is there, and you have to treat the patient. Because hard tissue, maturation growth is well known, but soft tissue, this capsule, ligament, aponeurosis, maturation, very little known about that. And in 1985, when I was working at Saint-Vincent-de-Paul, I asked my resident, Stefan Wolf, to look on the patients that I was treating with a brace for lumbar scoliosis after research 3-4. And he demonstrates the efficacy proven. And now, in a recent meeting in Japan, this was confirmed. And you see that with 3-year follow-up, improvement at that level where it is very important, lumbar spine, improvement with the treatment late. So walking, moving, horizontal plane give a very smooth adaptation of the skeleton about gravity, motion, poorly documented, ignored by the orthopedic surgeon, but better understood by the prosthetic and orthosis patient. You see, spine and horizontal plane. When you see this picture, you are not, you have not the ability to read it clearly, but when you look precisely, you can determine the positioning in the horizontal plane, in the frontal plane, in the sagittal plane, everywhere. But it is necessary to learn about that. Remember that I defined in the past that I call the spinal penetration index. This was coming from what? For the fourth type of hump you can observe. For example, you have in A, the exothoracic, classical, convex, bulging. In addition, on the opposite side, you have the in hollow, missing, exothoracic, concave. But the penetration of protrusion of the vertebral body inside the chest determine the spinal penetration index. And this is an important finding because with the EOS imaging, you can get the landmark of the ribs, and you have, of course, the spine that is very well represented, so you can determine easily this spinal penetration index. For example, here you see the patient before, you see the patient after in his brace, you see some kind of correction. It is not perfect, but you can analyze this very clearly from the view from the top. And in the thesis of Aurélien Courvoisier, a French orthopedic surgeon working in Grenoble, when you see, he did his thesis in 2012, comparing the result with brace and without brace, with this view from the top, this view of the spine as well on the chest. And you can say, when you have on the right your brace, you can say to the brace maker, you see, your brace is not at all useful, you have to change it. Of course, it is much better demonstrated by this view from the top. We design in our country that we call the 3D brace. The 3D brace is a spring effect from the flexible carbon fiber. You see the shape it has. And this brace create, as you can see on the right, before the first exam, the progression and inside the 3D brace. This brace create axial corrective force, detorsion, kyphosis in the horizontal plane, induced by the respiratory function of the patient. For example, here you see very well that the brace work, and here, for example, you will see how this brace work. If it will work, I don't know why the machine don't work now, but perhaps non, il ne veut pas aller, alors c'est comme ça, il ne veut pas aller, il ne veut pas aller. Ah, peut-être là. J'aurais bien voulu que ça marche quand même.
Jean, do you want us to advance the slides?
I don't know.
How many more slides do you have?
A small movie here to show how it works, but I don't want. Cannot
hit the button one more time, otherwise Ben can possibly try.
I don't know why.
Maybe I know it's a great video. Maybe we can just proceed.
It is a pity because you will see much better afterward, but I don't know how to put the video working.
It doesn't look like the video is working, Dr. Dubousset.
We may have to proceed without the video.
I don't think the video is going to work.
You think you will be working?
I don't think it's going to work.
Let's just proceed.
It don't work. Bon.
Right.
We will put it on the final video for the website.
It is bien dommage, mais ça fait rien. It is dommage. You will have see automatique, je sais pas pourquoi. Ça devrait marcher. Eh ben voilà, ça marche pas. Voilà, bon. Eh ben, tant pis. You will see how this machine work, because you have the correction because the proper modeling of the carbon support make you the chest moving with the respiratory function. And anyway, you have understood my mind. That is the most important thing. But I will tell you that this type of brace in my opinion, revolutionize completely the brace treatment of the scoliosis, only thinking about the horizontal plane. So remember that the human standing, you have the confusion between alignment and alignment. EOS imaging, you will give an excellent application of alignment. But balance is dynamic. The cone of economy that you see here, all the movement of the body are able to maintain the gravity with a minimum of muscle function. This is the basis. And Ronadat and Isadore Lieberman in Dallas try to quantify this cone of economy, and they did a very good examination, very good work comparing with the EMG between degenerative scoliosis and control, and show clearly the function very important of the gluteus maximus and rectus spinae. And most of the sagittal disorder, of course, were on the sagittal plane. My friend Kazuhiro Isegawa in Japan, you see this use the horizontal plane very, very clearly. And you see here this degenerative lumbar. But when you see the reconstruction, frontal, coronal, don't forget the view from the top. That is, for me, the most important. And you see, when you have the whole body top view, preoperative, you see here with the shape of the head, the gravity center, the feet, the knee, the ankle, the knee, the hip. You have a view, really functional view. And when the patient is treated, you can compare. You can compare before and after, and then you can appreciate much better than the Cobb angle that show you only the collapsing and nothing else. Here you appreciate much more a 3D reconstruction of your spine. And you see here, you have the center of the sacral base, you have the positioning of the head, you have the positioning of the feet, everything. It is a new way to approach the spine. So this vision of the horizontal plane starts to be considered. Ramadams, Isidore Lieberman, quantifies the cone of economy, alignment of the whole body, evaluation of the view from the top, very useful and reliable, very reliable. So these two factors, vertebral vector, whole body spine projection on the horizontal plane, for me, will become the new 3D reference for alignment of the deformity. Conclusion. You see that the 3D aspect of the spinal deformity is still a challenge. Larry Lenke vision and classification was a major step for the 2D analysis and treatment. The global top view and the vertebral vector introduce a friendlier horizontal plane vision. It must be complement to reach a real 3D evaluation of the alignment. But remember always that the clinical functional evaluation is still mandatory to assess properly the balance. So for the young researcher, remember that everything remains to be done. Shadow are multiple, new horizon, numerous, infinite, and like was saying Matthew, chapter 6, 7, seek after, and you will find it. Thanks very much, my friend, and I hope that you will ask me questions in order that I can answer you. I see you. I see all the room. It is clear. Nice.
Professor Dubousset, thank you so much for sharing your thoughts, your latest iteration of a long, rich history of vision. Can you back up a little bit so we can see your full face? Right now we just see... Très bien, lower your camera a little bit. There.
Like that.
Très bien.
It's better for you.
Much better.
Okay.
The whole you.
Okay.
Excellent. So this was, again, visionary. And of course, everything makes sense what you say, and we've just overlooked it for all this time. And I remember when at Texas Scottish Rite, you introduced the concept of crankshaft to us, and you called it crankshaft in front of a group of Texas surgeons, and everybody's mouths were open, going like, what? I remember the 3 cases they showed, and they all had crankshaft as a problem, and the proud Texas surgeons were so disappointed that they couldn't figure out what happened. Here comes a French professor, and it's all easy, it's all clear. Now, my question to you about the derotation or rotation of the spine is twofold. Number one, you've given us degrees which are simple. We can all measure them. We can have a 2-dimensional replication with lumbar lordosis, PI, whatever, PT, mismatch. We can measure these things easily. If we don't have the benefit of EOS, how can we quantify this complex 3-dimensional superimposition of the foramen magnum and spinal canal over the feet? Is there a simple way to quantify that, or is this the problem why we can't kind of put that into our everyday practice more commonly?
I think the most important thing for that is to think about. This is the first thing. So when you have think about that, then you have some way to try to quantify. It is why I show you all these things with the vertebral vector, with the view from the top coming from Kazuhiro Hasegawa. That is the view from the top, including the head, because remember that in the chain of balance, I described a long time ago the important role of the pelvic vertebra. That was the entire pelvis considers that one vertebra, and the entire head considers that one vertebra with his weight. So it is important to not be addicted from so many years, yes, to this AP and sagittal. When you lose all the physiology of the spine, that is first head, very heavy. The head is heavy and give a lot. For example, more I look about the so-called PGK. You have PGK all the time, and more you will extend your fusion at the upper part. If you don't check about the active mobility from the upper part of your head, of your shoulder, etc., you will never get out of this problem. So to measure it, it's first to think. Second, if you use the EOS system, you will approach much better the way by I told you, by the vertebral vector and by the projection of the head, like did Kazu Hasegawa.
Can I have a question?
Do we have another question?
Yes.
Dr. Pimenta is here. Luis is here. He has a question for you, Jean.
Hi, Jean.
Okay.
Yeah, a long time I don't see you. Great talk. I'm super interested in the idea on degenerative cases to evaluate. Usually we, in degenerative surgeries in the lumbar spine, we look much more on the sagittal alignment. I'm curious, in predicting adjacent level disease, how much the horizontal defect would affect degenerative, because when we talk about PJK, in degenerative is adjacent level, which is basically the same in my opinion, right? So is it, in your mind, also important, let's say we have a two-level lateral listhesis, early stage of degenerative scoliosis with stenosis, should we address better the rotational effect in order to avoid adjacent level disease?
Of course. It is why when you have such type of deformity, the most important thing is to check with X-ray, because we have not yet everything, active correction, as well for the upper part, as well for the lower part, in bending, anterior, posterior, and checking exactly the active motion around the level you are discussing to put inside the fusion or not inside the fusion. And remember that more you extend the fusion, less you have possibility of compensation. The important word that we have to have in an armamentarium, it's compensation. When you have the possibility to compensate, then it is why the race to the better curb angle for me is a mistake.
Jean, are you saying that doing more surgery, bigger surgery, you allow a short future for the patient?
Oh yes,
so many times I see too big corrections, right?
Exactly, I agree completely.
Everything is T10 to the pelvis or T4 to the pelvis, right? There is no other answer to problems. So I'm saying that frequently you have one problem, a deformity, and the quick answer is T10 to the pelvis or T4 to the pelvis, nothing in between.
This is not a good way to do, because when you have to decide to go to the pelvis, you have to check many things, and especially the motion of the hip joint, the reserve of extension, because from time to time you have a hip joint contracture, and then it is not good for the future. So you have to check the entire spine, and especially the motion of every segment. And so I don't like very much when you say T10 pelvis. No. And for example, when you go at the upper part, you will extend your instrumentation more and more, especially because of the screw, because the screw push you to try to get the best curb angle. It is not that. Why, when I design the rotation of the pre-bent rod, instead of going step by step, try to get the best curb angle. No. When you do the rotation of the pre-bent rod, you have motion everywhere, some adaptation, but you will not get the best curb angle. You understand? This is my philosophy.
We need to move on. Great questions, but I have one last question for you, Jean, but I need a fast answer, because otherwise we have to have a whole day spine master of masters conference just with you, because that's how important you are. Is there a difference, and this is my question, in derotation between kids and older adults with scoliosis? The reason being, in kids it's easy to derotate. They have strong bone. They usually don't have strong or big osteophytes. in the usual postmenopausal osteoporotic, mostly female patient, there are large osteophytes, there's a lot of osteoporosis. How important is it, in your opinion, to derotate such an elderly spinal deformity if we succeed in restoring sagittal and coronal parameters?
Yeah, it is. When you try to get the rotation, it's especially to prevent destabilization. Because when you are in a positioning of you have, especially at the junction, I don't like remaining rotation. So on such case, don't hesitate to jump one level. If for example, the lower end vertebra is an unstable position, don't leave it like that, because it will progress after all the way, all the time. So don't try too much to get this derotation, but to prevent the instability. And this is the main message.
Many, many more points in several chats, but we must proceed. But hopefully we can count upon you still being with us and following us and commenting on the many great lectures to come with Dr. Siepe and Dr. Arlet in the wings waiting. So thank you, Jean, and stay tuned for more. And we'll switch to the lab now.